Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to the channel of Stand Medical Notes, or you can also call it as lecture. So today let us discuss about the management of diabetic eye disease. Let's begin with the name of Almighty. So managing diabetic eye disease demands a dual pronged approach. Number one, relentless systemic metabolic control managed by the primary care physician or the endocrinologist, coupled with number two, aggressive targeted ocular interventions executed by the retina specialist. So uh, two persons play a role here. One is the primary care physician or the endocrinologist, second is the retina specialist. So primary care physician will control those factors which are systemic, and the eye specialist will take care of those problems which are present in the eyes. So these are the two things. Okay, coming to the first one, the systemic factors, chronic systemic management, which is the foundation. So in that, the number one is intensive glycemic control. Okay, second is blood pressure control, third one is lipid lowering therapy, and the role of fenofibrate role in diabetic retinopathy. So let's see one by one. The diabetes control and complications trial, DCCT1 for type 1 diabetes and UKPDS for type 2 diabetes, unequivocally proved that intensive glycemic control prevents the onset and slows the progression of all microvascular complications, including your diabetic retinopathy. Okay, a generalized reduction in HbA1c of just 1% yields an approximate 30 to 35% relative risk reduction in microvascular endpoints, including the need for retinal photocoagulation. If you reduce the HbA1c by 1%, you will have an effect of 30 to 35%. So that's very much. And the legacy effect you already know. So extended 10-year follow-ups of these trials revealed that patients subjected to intensive early glycemic control maintained a significantly lower risk of retinopathy decades later, even if their HbA1c subsequently deteriorated to match the conventionally treated group. Early metabolic memory protects the endothelium. So if you take care now, forget later. In simple words, meaning your present action will take care of your future. Your present action will take care of future in the form of effect, in the form of reduction of complications, in the form of reduction in the incidence of complications. So that is legacy effect. Okay, so 1% reduction of HbA1c will have an effect of reduction of complications by 30 to 35%. Second is blood pressure optimization. So strict blood pressure control, target less than 130/80, reduces the risk of stroke and MI, and simultaneously retards the progression of diabetic retinopathy and diabetic macular edema. And in that, the use of ACE inhibitors and ARBs confers specialized microvascular protection beyond basic mechanical pressure reduction. So that means you should use these drugs in patients. So they have an additional benefit apart from reducing the BP. The third one is lipid lowering and the phenofibrate pattern, which is seen in trials. While statins are universally indicated for macrovascular protection, the specific use of PPAR alpha agonist, that is phenofibrate, this is also a lipid lowering drug. Okay, fibrates category has revolutionized diabetic retinopathy medical management. A massive field and accord eye clinical trials demonstrated that administering phenofibrate significantly slows the progression of established diabetic retinopathy and dramatically reduces the requirement for laser photocoagulation therapy. So you should add up this drug to your lipid lowering regimen in patients who are having diabetic retinopathy. Crucial clinical logic, the productive retinal benefit operates entirely independent of the drug's systemic lipid lowering efficacy, indicating a direct organ specific protective mechanism on the retinal microvascular similar to the ACE and ARBs. Okay, that's why these drugs should be used in systemic control of these factors. Okay, that is about the one part. Okay, that is your controlling the first, and it is also very very important part, that the control of the systemic targets, controlling the HbA1c, controlling the blood pressure with AC inhibitors or ARBs, lipid lowering drugs, including phenofibrate in the lipid lowering drugs. All these things will reduce the progression of diabetic retinopathy. Now comes the second part, that is ocular interventional strategies. Okay, that is taken care of by the retina specialist. So modern ocular intervention is heavily dictated by the landmark protocols established by the Diabetic Retinopathy Clinical Research Network. Now, management in the first, management of the proliferative diabetic retinopathy, PDR. Historically, the gold standard thing was pan-retinal photocoagulation. What was that? Scatter 1500 to 2000 thermal laser burns across the peripheral retina. How it acts? It destroys the ischemic peripheral photoreceptors, decreases the oxygen demand, reduces the VEGF production, and causes neovascular regression. It is similar to your heart, where you use the beta blockers. So beta blockers will reduce the activity of heart and thus reduce the oxygen demand. Okay, and thus protect your reduce your cardiac remodeling. Okay, similarly, when you are burning typical ischemic sites on the retina, so you are reducing the total oxygen consumption. So when there is reduced demand of oxygen, there will be reduced VEGF production, and that will decrease the neovascularization. Now that was the old thing. Now the modern thing, what is fire trial comparing pan-retinal photocoagulation versus intravitreal, meaning in the vitreous tumor, injection of ranibizumab, anti-VEGF injection. So there are many anti-VEGF injection, among them one is ranibizumab. So what are the outcomes of this trial? Outcome: ranibizumab was non-inferior to pan-retinal photocoagulation for visual acuity, lower rates of vision impairing diabetic macular edema, avoids peripheral visual field loss which is caused by pan-retinal photocoagulation, because basically this pan-retinal photocoagulation which we are giving peripherally, it is burning the retina. So peripherally the patient will be losing vision. So that will be that can be stopped by using this ranibizumab. So that is non-inferior, that means it is equivalent to pan-retinal photocoagulation. And these anti-VEGF injections along with retinopathy, they also control this diabetic, they take care of this diabetic macular edema. Okay, and alongside, one benefit is patient will not lose his peripheral vision. So now the management decision from this trial: both anti-VEGF and PRP are effective first line options. Okay, anti-VEGF requires monthly compliance. If lost to follow-up, rapid rebound neovascularization can occur. This is the main problem with these anti-VEGF injection. If patient doesn't follow up regularly and doesn't take these injections regularly, then there will be rebound neovascularization, and there will be very progressive and sudden damage of retina because of this rebound neovascularization. That is the main drawback of this anti-VEGF injections. Whereas PRP, patient takes once and that is permanent damage. So there is nothing like that rebound neovascularization in the case of PRP. So PRP is destructive, but it is permanent. So there is no risk of rebound neovascularization in case of PRP. Choice depends on patient reliability and adherence. That was what management of PDR. Coming to the management of DME. So mainly this DME is managed by intravitreal anti-VEGF injections. Remember, so they have completely replaced focal laser as the first line therapy for center involved DME with visual impairment. Now agent selection compared depending upon, so from the trial compared 3 anti-VEGF drugs over 2 years. So there are 4 to 5 I think drugs, actually anti-VEGF drugs. So there is a trial, DR CR net protocol T. So 3 anti-VEGF drugs are studied over 2 years and they are compared. Okay, so suppose the patient has a baseline visual acuity of 20 by 32 or 20 by 40, which means there is a mild impairment of vision. Then all the three agents, which are those three agents, aflibercept, ranibizumab, bevacizumab, performed equally well, meaning in mild reduction in visual acuity due to diabetic macular edema. All these three anti-VEGF injections, aflibercept, bevacizumab, ranibizumab, all performed equally well, and visual improvement was about 8 letters. Okay. Now, in case of moderate to severe impairment, so mild impairment is defined as less than 20 by 40 visual acuity, and moderate to severe is defined as equal to or more than 20 by 50 visual acuity. Remember this point. Okay. Now, in this case, in moderate to severe impairment due to diabetic macular edema, aflibercept was superior at 1 year. So among these three, aflibercept was superior in case of moderate to severe cases. So aflibercept, there was improvement of approximately 19 letters, and second to that is ranibizumab, there was improvement to approximately 14 letters, and the third and last one is the bevacizumab, there was improvement of approximately 12 letters. At 2 years, aflibercept remained superior to bevacizumab. So aflibercept remained superior to bevacizumab at 2 years. Okay, so these are the key findings of this trial. So 3 injections are studied: aflibercept, ranibizumab, and bevacizumab. Now, according to DRCR net protocol AC, we can have a step therapy like this. We will start with a cheaper drug like bevacizumab. Okay, then we will switch to aflibercept only if the DME does not improve by 12 weeks, meaning 3 months. 3 months, if the DME doesn't resolve, then we will shift to aflibercept. So yields are acceptable, slightly inferior, long-term visual results compared to starting aflibercept immediately. So you can start with bevacizumab and then you can go on to aflibercept. Aflibercept is costly, bevacizumab is not costly, but if you start from initial only aflibercept, then it is good, but it is costly. So this is one protocol the eye specialist can follow. So we have studied PDR, DME. Now coming to NPDR. So in NPDR, mild to moderate, we don't take any action. The problem is in severe NPDR. In case of severe NPDR, what should we do? So actually there is a clinical dilemma. If anti-VEGF works for PDR and DME, should we use it proactively in severe NPDR to prevent binding complications? So there is a question mark actually, we don't know. What does the evidence say? 4-year trial of prophylactic aflibercept in severe NPDR without diabetic macular edema. So this evidence, what are the outcomes? So this reduced the development of PDR and CIDME in more than 50% of cases. In more than 50% of cases. When you are using aflibercept for severe NPDR, reduce the incidence of development of PDR and CIDME in more than 50% of patients. These are the outcomes. But remember, it developed the PDR, reduced the development of PDR, CIDME, but there was no difference in visual acuity at 4 years compared to the wait and watch group. That means visual acuity is not improving, just you are delaying the development of PDR and CIDME. So what is the decision then? Routine prophylactic anti-VEGF for NPDR without CIDME. Remember this point. Anti-VEGF for NPDR without CIDME is not warranted. Okay, if CIDME is present, then no matter it is mild, moderate or severe NPDR, you have to use anti-VEGF injections to control this CIDME. But even with severe NPDR without CIDME, you should not use anti-VEGF injections. This is the study that is saying, okay, standard care is to monitor the patient. That's all. Rigorous monitoring should be done. Treat only when vision threatening complications occur. So what is the rationale behind that? This avoids the unnecessary burden, cost, and infection risk of long-term injection. Remember, you are giving anti-VEGF injections into the eye. There is a great risk of endophthalmitis in these patients, dangerous complication. So that's why. So for severe NPDR, what is the rule? If there is no CIDME, you should monitor the patient. If it is associated with CIDME, then you can give anti-VEGF injection. Now in advanced refractory disease, what you should do? There are two options. Number one is corticosteroids. Number two is pars plana vitrectomy. So corticosteroids, so refractory means not responding to pan-retinal photocoagulation as well as anti-VEGF. To both it is not responding. So that is advanced refractory disease. So two options are there: intravitreal corticosteroids or pars plana vitrectomy. So corticosteroids are indicated for patients who are refractory to anti-VEGF or who are pseudophakic, meaning post-cataract surgery. What we will do here? Intravitreal sustained release corticosteroid implants containing dexamethasone or fluocinolone combat non-VEGF inflammatory cytokines driving the chronic edema. So what is this pseudophakic? Pseudophakic cystoid macular edema. We have studied no differential diagnosis. So sometimes after cataract surgery there is development of macular edema, that is known as pseudophakic cystoid macular edema. So there also we use this corticosteroid implants. The second option is pars plana vitrectomy. This is reserved for end stage scenarios. Okay. So what you will do here? Aspirate the dense vitreous hemorrhage that does not clear spontaneously after several months of anti-VEGF therapy or intravitreal steroids. And second thing is, in tractional retinal detachment, peeling and delaminating fibrovascular membranes to repair the tractional retinal detachment. This is a surgical approach, and surgical approach is the last thing which we are doing in the end stage scenarios. Key takeaways: treatment must be individualized based on disease severity, clinical trial evidence, patient compliance, and risk benefit considerations to preserve and improve the vision. So treatment differs in all these things. So in PDR, so either you can use PRP or you can use ranibizumab. Okay, both of them have their merits and demerits in PDR. In DME, depends whether it is mild or whether it is moderate to severe. Okay, here PRP doesn't work in DME. You have to give anti-VEGF injection. Okay, but in anti-VEGF injection, the most effective is aflibercept, but it is costly. So it is good to start. One study says in mild DME, all of them are effective equally, but in moderate to severe, aflibercept is ranking the first position in all of them. So that is the thing. The third thing is severe NPDR. So severe NPDR should not be treated. It should be watched carefully for complications. It should be treated only when it is associated with CIDMA. And the last one is in the end stage disease which is not responding to anti-VEGF injections. You can give corticosteroid implants containing dexamethasone or fluocinolone, or the end stage disease we can go for surgery, opt for surgery. Okay. So now, what are the red flags and clinical in the clinical pitfalls? Okay, red flags and clinical pitfalls that we will see. So red flag, clinical pitfalls. So we should remember these things. Avoid these critical mistakes to prevent irreversible vision loss in diabetic eye disease. Tightening paradox, meaning suppose the HbA1c was 14% and immediately you have dropped the HbA1c to 6%. So that is not a good thing. Similar to the BP reduction. Suppose if the patient is having a high BP of some 200 systolic BP or 120 diastolic BP, you will not reduce BP directly because there is a risk of ischemic complications. Okay, so you will reduce gradually. Similarly, if you reduce this HbA1c rapidly, a high HbA1c, then there is a risk of worsening of retinopathy. That's why you should reduce the HbA1c gradually to prevent the worsening of retinopathy that we should think. So rapid ultra aggressive normalization of glucose in a patient with years of severe chronic hyperglycemia, example rapidly dropping HbA1c from 14 to 6% with an insulin pump, can paradoxically trigger a catastrophic acute worsening of retinopathy. The sudden drop in systemic glucose abruptly reduces retinal blood flow, severely exacerbating pre-existing tissue ischemia and triggering rapid onset PDR. Glucose must be lowered gradually in patients with established eye disease. This should be kept in mind. It should be reduced gradually in patients who are having diabetic eye disease. What happens? What happens if we reduce abruptly? Same thing, same funda here also. There will be reduced retinal blood flow and there will be trigger for PDR, catastrophic, acute. Okay, that is the first pitfall in systemic cause. Second is missing the rubiosis. So before checking, before doing fundoscopy, always slit lamp examination should be done for the iris to check for rubiosis, development of new vascularization. If it is not checked, then there is a risk of acute angle closure glaucoma attack. So that should be kept in mind. Third is loss to follow up on anti-VEGF. Very important. On anti-VEGF treatment, patient is there, so the new vascularization will be suppressed. Patient misses appointments. VEGF suppression wears off, and there will be rebound and complications like massive neovascularization and hemorrhage and detachment. So that patient should be informed that if you don't follow up properly, then your eyes will develop a dreaded complication. So this should be informed to the patient. So HbA1c should not drop abruptly, and don't miss rubiosis, and don't miss follow up in anti-VEGF. So these are the clinical pitfalls. Now coming to the individual drugs, okay, anti-VEGF drugs which we give in particularly diabetic macular edema. The pharmacological management of diabetic eye disease relies almost exclusively on biological agents injected directly into the vitreous cavity, intravitreal administration, bypassing systemic barriers to achieve massive local concentrations. Okay. Crucial procedural note: the most devastating complication of any intravitreal injection is infectious endophthalmitis, as I said previously. So the use of topical povidone iodine on the ocular surface prior to injection is the single most critical universally mandated prophylactic measure, as failing to use it results in unacceptably high rates of endophthalmitis. So topical povidone iodine therapy before anti-VEGF injection is very important. Key points: intravitreal therapy develops high drug levels directly where needed with minimal systemic exposure. Regular scheduled injections are important for maintaining efficacy. Close monitoring for response and side effects is essential. Okay, early treatment adherence to follow up are key to preserving infection. So let us now come to individual drugs. So we have the trial studied 3 drugs. So we will discuss 3 drugs. So one drug is anti-VEGF monoclonal antibody fragment, that is ranibizumab. So this is very, as we have learned that, so this is the dose. If you want to know the dose, just to stop the video and you see. So mechanism is it will suppress VEGF-A, but the risks are endophthalmitis, retinal detachment, and transient intraocular pressure elevation. Caution: small but theoretical risk of arterial thromboembolic events like stroke and MI. Second and very important drug is aflibercept, which ranks first in among the 3 drugs. So mechanism is a potent VEGF trap, so that tightly binds VEGF-A and VEGF-B both, and also placental growth factor. 3 things it is binding. So the clinical use is absolute drug of choice for severe DME, where the visual acuity is more than 20/50 or equal to 50. Okay, that we have studied already. Faricimab is also a one drug, okay, but it is not studied in trials. The specialty of faricimab is it will block both VEGF-A as well as angiopoietin 2. So here one thing is there, angiopoietin 2 it will bind. So blocking angiopoietin 2 stabilizes the endothelial cell wall and further reduces the vascular leakage. Benefit: achieves much longer duration of action, drastically reducing the patient's injection burden. Faricimab, okay. Well, other one is brolucizumab, okay, but it is very effective, but there is a severe black box warning for causing vision threatening intraocular inflammation, retinal vasculitis, retinal vascular exclusion. This is one important thing. So anti-VEGF full monoclonal antibody. So this is the use, okay, FDA approved for systemic oncology, So it was approved for oncology, but it is used for retinopathy. But used ubiquitously, ubiquitously off-label for eyes due to massive cost savings. It is cheaper. Must be compounded by specialty pharmacies. Slight increased risk of infection or silicone oil droplets if improperly prepared. So cost-effective alternative, efficacy comparable to other anti-VEGF agents in many studies. Risk again same: endophthalmitis, retinal detachment, transient elevation of IOP, arterial and thromboembolic events, stroke and MI. So next comes in refractory disease, the implantable steroids like dexamethasone and fluocinolone, these two. So dexamethasone indication is second line for DME, which is refractory to anti-VEGF, or in pregnant or pseudophakic patients. Severe side effects are there, universal progression of cataracts. So avoid in phakic patients who are having the lens, okay, and high risk of steroid induced glaucoma requiring surgical infiltration. So in these patients we should avoid, who are having natural lens in their eye, okay, and who are having a high risk of glaucoma, there we should not use this steroid. Then comes the fluocinolone indication, again same, chronic recalcitrant refractory DME. Side effects are similar massive risk of cataractogenesis and intractable ocular hypertension, meaning glaucoma. And this is one lipid lowering drug, fenofibrate, which is studied. The dosage is 160 to 200 mg taken orally once daily. It is a systemic adjunct therapy proven to delay the progression of early DR to advanced stages. Contraindication, absolute contraindication in severe renal impairment when the eGFR falls less than 15. Okay. Now coming to some special situations. The first situation is pregnancy. So the situations are three mainly. One is pregnancy, second is renal impairment, third is concurrent cardiovascular disease. So coming to first, pregnancy. Okay. The extreme risk. Pregnancy induces massive, rapid physiological, metabolic and hormonal shifts that can drastically accelerate the progression of pre-existing diabetic retinopathy, pushing a patient from mild NPDR to blinding PDR in a matter of months. So there is a high risk of progression. So patients who are pregnant, they should have a strict screening protocols. So they should have a pre-conception examination of their retina first, whenever they are planning to conceive. And if they are decided to conceive, then they have trimester every 3 months screening of their retina by fundoscopy. And even after delivery, they should have a screening up to 1 year post delivery period, postpartum, because there is a high chance up to 1 year after delivery of developing this PDR in these pregnant patients. So before becoming pregnant, they should undergo this screening. Then after pregnant, every trimester they should have scanning, and till 1 year after delivery they should have scanning. Now one important thing to clear is the gestational diabetes. So unlike the type 2 diabetes mellitus, which is present in some individuals, or type 1 diabetes mellitus, so from before delivery only, GDM which develops during pregnancy doesn't have any role in helping the progression of retinopathy. So that should be kept in mind. The GDM doesn't require anything monitoring. So GDM is transient, does not increase the risk of diabetic retinopathy. So there is no special eye screening required in case of GDM. Now there is a treatment dilemma. What should be done in these diabetic patients if they develop some complication during pregnancy? Anti-VEGF agents are heavily designed to block angiogenesis. Okay, so just here in the box only, the preferred one is the pan-retinal photocoagulation, PRP laser is preferred in pregnancy. This is the standard treatment during pregnancy for PDR. Why? If you use anti-VEGF injections, they have a high risk of crossing the placenta and causing teratogenicity in the fetus. That's why they are not used in pregnancy, anti-VEGF injections. And if at all, if you want to use, then you can use one anti-VEGF injections, and that with a short half-life, that is ranibizumab. Ranibizumab is the anti-VEGF of choice in pregnancy because of its short half-life. For DME, dexamethasone implant is an alternative option for DME. Okay, so that is the thing. Okay, So PRP is the gold standard in pregnancy, but if you want to use, you can use ranibizumab, which has a short half-life. Okay, and alternative to this anti-VEGF, you can also use dexamethasone implant also. So one important thing to remember about the fenofibrate dosing in renal impairment patients. So if the eGFR is equal to or more than 60, the dosage is 160 to 200. If it is 15 to 60, then reduce the dose to half, meaning from 70 to 140, 70 to 135, you can remember, 70 to 135. If it is less than 50, then discontinue the drug or it is contraindicated, because if eGFR is less than 15, there is a risk of reversible increases in serum creatinine and rhabdomyolysis, high risk. And second thing, in fluorescein angiography, fluorescein dye is metabolized in liver. There is a rival metabolism, but it is excreted through kidney. So in end stage renal disease, there is delayed clearance of the dye. So what will happen in end stage, if given in patients with end stage renal disease, that will accumulate and cause prolonged yellow discoloration of skin and urine. So use with careful and clinical judgment. So these two things should be kept in mind in case of end stage or any patient who is having DKD, which is usually associated in patient with who are having diabetic eye disease, fenofibrate dosing and fluorescein. Third thing is there will be concurrent cardiovascular disease. So one dilemma is, so aspirin usually it is an anticoagulant, so antiplatelet. Okay, so it causes bleeding. So all the pathology of diabetic retinopathy or DME is because of leakages, hemorrhages. So one thing comes in mind that if you use aspirin, then there will be leakage and there will be worsening of retinopathy because of hemorrhages. But that is not the thing. That is not the thing. What the ADA recommends is give aspirin to these patients to prevent cardiovascular disease complications, as there is no evidence-based leakage or increase or worsening of retinopathy patients who are receiving aspirin. So do not stop aspirin solely due to diabetic retinopathy. Continue aspirin for cardioprotection unless other contraindications exist. So that is important, but aspirin should be started in these patients. Okay, this is the what you call your one page summary. You can see here, this is one page summary. Okay, now we will discuss one practical case of diabetic eye disease, diabetic retinopathy. Here is a patient by name Mr. Rajesh Kumar, who is aged 56 years, and he is a shopkeeper by occupation. His chief complaints are blurring of vision in both eyes for 6 months, difficulty in reading newspaper, glare while driving at night, floaters in the right eye for 2 weeks. So this is pointing towards PDR, and difficulty reading this pointing towards DME. Okay, let us see. History taking. He has a type 2 diabetes mellitus for 14 years. Poorly compliant to medications, never underwent retinal screening. So this is the main thing which we see in these patients. Last HbA1c was done 2 years ago, and it was 9.5%. Currently he is on medicines like metformin 5 mg BD and glimepiride 2 mg OD. Other risk factors are hypertension from 8 years, dyslipidemia is present, smoking from 20 years, BMI is more than 30, no previous laser treatment. So what should we ask in this patient? Whether there is a history of sudden vision loss, history of floaters we should ask, history of flashes of light, history of distorted vision, history of difficulty reading, history of night vision, history of pain in the eye, glaucoma, history of red eye. Now in these symptoms we have these things: floaters, progressive blurring, but there is no pain. No pain means no glaucoma like thing. Okay, on examination vitals are BP 160 by 96 raised, pulse 82, weight 86, BMI more than 30. Systemic evaluation, foot examination is normal, urinary microalbumin is present, meaning UACR is positive in these patients. Okay, and meaning this patient eGFR is 58, which is less than 60. That means the patient is also having diabetic kidney disease. Okay, eye examination, visual acuity in the right eye is 6 by 18, in the left eye it is 6 by 12. Near vision it is reduced, IOP is normal, thank to God. Pupils, they are also normal. Now fundus examination dilated. So before fundus examination, always the patient should undergo slit lamp examination to rule out rubiosis. That is not given here. Okay, in the right eye on fundoscopy we see multiple microaneurysms, exudates, cotton wool spots. Okay, everything is there. Multiple microaneurysms, dot hemorrhages, venous bleeding, cotton wool spots, neovascularization of the disc also Okay, hard exudates. In the left eye, numerous microorganisms, hemorrhages, hard exudates, and there is macular edema also. Okay, so what is the diagnosis? Right eye, there is PDR with CIDME, and in the left eye, there is severe NPDR along with CIDME. That means left eye also needs treatment because severe NPDR is associated with DME. If it was not associated, then we should have monitored just, but it is associated, then it should also get treated, and this should also get treated. Okay, now what are the investigations? HbA1c now is 10 to 10.2%, CBC is normal, creatinine is raised 1.4, eGFR is 48, albumin is positive, LDL you see 142, it is very much high, LFT is normal. OCT was done in this patient, so there was retinal thickening, intraretinal cyst, central macula, CIDM is present in this patient. Fundus photography, there is severe fundus photography should be done because it documents the severity. Fluorescein angiography, there were areas of ischemia, leakage, new vessels, macular leakage. Okay, you know this pathophysiology already. Now what are the treatment goals? So the diagnosis already is established, and this fluorescein angiography is also done, and OCT is also done. So treatment goals: preserve the vision, stop the progression, reduce the macular edema, prevent vitreous hemorrhage, prevent retinal detachment, optimize the systemic risk factors. Two things, no? We should correct the systemic factor and we should correct the local factors. Two things. So we are optimizing diabetes. We are stopping glimepiride and we are starting metformin continue. Sorry. So we should continue metformin in this patient. Okay. 1000 mg twice daily. Empagliflozin should be started because the patient is having DKD, diabetic kidney disease. Semaglutide should be because the patient is already obese, he is having weight, and he's having DKD also. So ideally we should go for semaglutide and target the HbA1c to approximately 7% in this patient, 7 to 7.5%. Okay. So blood pressure target should be less than 130. Drugs, elmisartan should be started, AC inhibitor should be started. Lipid management. So here there is a actually one mistake. So here atorvastatin we are starting, but we should start a combination of statin along with fenofibrate because fenofibrate has an efficacy in halting the progression of retinopathy, but here it is not given like that. Okay, it is a dummy case actually. Visit 1 anti-VEGF injection was given, so you can do any one of this. In mild you choose bevacizumab. If moderate is here, you choose aflibercept. In pregnant ladies you choose ranibizumab. So visit 2 weeks, after 1 week repeat anti-VEGF injection and repeat OCT. Okay, when NVC regresses, perform pan-retinal coagulation. Okay, visit for complete PRP. In further sessions continue OCT guided anti-VEGF injections. Okay. Okay, so these are, if something happens, what should be done. So this you can do. This is lifestyle: stop smoking, aim for gradual weight loss, follow diabetic diet, walk for more than 150 minutes, monitor BP and glucose regularly, never skip annual eye examinations, retina review every 4 to 8 weeks, OCT at each treatment, HbA1c every 3 months, BP every visit, lipid profile every 6 to 12 months, kidney function every 6 months. Now what was the outcome in after 6 months? HbA1c was dropped to 7.3%, BP was dropped to 126 by 78, LDL is less than 70, which is in the target according to American Diabetes Association. Okay, vision is improved. See, it was 6 by 10 to 6 to 9, 6 by 12 to 6 by 6. In OCT there is reduction in macular edema. Fundus, neovascularization was regressed. There was no vitreous hemorrhage. Retina is stable after pan-retinal photocoagulation and anti-VEGF. Okay, that was all about diabetic retinopathy. Thank you. We will discuss in the next videos, in the coming videos, about diabetic neuropathy. Thank you.